Good day, ladies and gentlemen. Infertility is a very, very common problem all over the world. Many of the patients with infertility will undergo one form of surgery or the other. So we know that in patients with infertility, there are various management options. These include expectant management, where we just give advice on the ovulation window, timed intercourse, and stuff like that, lifestyle changes. And then there's medical management options. These include ovulation induction, intrauterine insemination, and finally assisted reproduction in the form of IVF or ICSI. And finally, and the third option is the surgical option. Now, we are going to talk about this option, the third option amongst all three options. Now, what is the role of surgery in patients with infertility? Surgery essentially has got three roles to play in patients with infertility. The first role is to use it as primary treatment for infertility. In other words, we do surgery so that the patient can fall pregnant after the surgery. The second role is to enhance the fertility. In other words, we make the chances of implantation of the pregnancy staying and not getting lost, we improve those chances. And finally, the aim of surgery may be to preserve fertility. Now, we will not be talking about fertility preservation surgery. That's a topic for another doctor to present. So I will talk about the first two places of surgery. Now, in the reproductive system, there are really four structures that affect our fertility. And we do surgery generally in those four structures. We'll talk about surgery in the ovary. We'll talk about surgery on the uterus or in the uterus. We'll then talk about surgery on the fallopian tubes. And finally, the other part simply means generally the peritoneum. And the most frequent other cause where we do surgery would be endometriosis. So we'll see what is the place of surgery for endometriosis in the management of patients with infertility. So let's start with the ovary. Now, I want to make a general statement about the ovary. In general, surgery for the ovary is bad for fertility. Having said that, remember that a lot of patients would come to the doctors because they've got ovarian cysts or all sorts of stuff. It is important for the patients to understand that ovarian cysts are normal structures in the main. Every month, a woman will form a cyst because inside that cyst is the eggs. So we don't routinely go around removing ovarian cysts simply because they are there. The other problem that we see frequently is the so-called ovarian drilling. This happens in patients with PCOS. Now, there's a picture there with an ovary with lots of holes. That's called ovarian drilling. That is a badly done procedure. Every operation done on the ovaries will damage the ovarian reserve, which means that it's going to deplete the ovarian eggs that you have, and thus be very, very careful if the doctor requests that you must have surgery for the ovary. Of course, there's a place for ovarian drilling, but it must be done appropriately and preferably by a fertility specialist. And it is done under very specific conditions. Not all patients with PCOS will benefit from ovarian drilling. So please note that there is no place for ovarian cystectomy except if somebody presents with an acute abdominal pain. If the ovarian cyst is big, usually more than 10 centimeters, and it undergoes torsion, then there may be a place to remove that cyst. In general, we just detort the ovary and we wait and not remove anything. Of course, if there's cancer in the ovary, it must be removed. Sometimes patients go to theater for something else, and then they incidentally find an ovarian cyst. Now, there is no place to remove an incidental finding. If it doesn't cause problems, you leave it. Don't remove it because it's simply because it's there. And the biggest problem that we see is patients with endometriosis of the ovaries, called the endometrioma. Now we know that endometrioma per se doesn't cause pain, and endometrioma per se doesn't cause infertility. But the tendency is to remove it because it's there. Occasionally we have to reduce the size of the endometrioma to make it easier for us to access the other follicles when we do IVF. There are specific ways in which we operate endometrioma, and your endometriosis specialist will know how to do it, not the average gynecologist. Now let's talk about the uterus. So we said the ovary in general don't do surgery. It's generally bad for fertility. So when it comes to the uterus, we know that fibroids are very, very common, especially in African patients. We all know that 1 in 3 ladies have fibroids. But the majority of those fibroids do not cause problems, and the majority of those fibroids do not need to be removed. Because if you remove them, you do nothing to the pregnancy rate. So there's no point in removing the fibroids that don't cause a problem. The second common problem we see in the uterus is uterine polyps. Now, in general, these polyps do not cause any problem, so we don't have to remove them. There's no evidence that removing of uterine polyps will improve the pregnancy rate. So don't remove them unnecessarily, unless if there's a specific problem, like heavy menstrual bleeding or a history of previous miscarriages. Then we may consider to remove them. And finally, we know that miscarriages are pretty much common, unfortunately. We know that up to 70% of our patients will lose their pregnancies. Now, the trend amongst all the practitioners is that if there's a miscarriage, the patients get a womb scrub or a DNC. Now, as it says womb scrub, you scrub the womb. And if you do that, you induce a lot of scars in the womb. Now, if there are scars in the womb, those scars are going to impair your pregnancy rate. It's going to make pregnancy very, very difficult. So we don't like scarring of the womb. So one needs to avoid womb scrubs at all costs. Some patients would come to us and say, "Doctor, can you please clean my womb?" It is the wrong thing to do. The womb is generally clean. There's no need to clean the womb. Because cleaning the womb means you must scrape off the good tissue, and you're going to create serious problems. No place for womb scrub and womb cleaning. So what do we then do? If there are problems in the uterine cavity where the baby should sit, we recommend that rather do a hysteroscopy instead of a womb scrub. Because with the hysteroscopy, you put in a telescope inside, you see exactly where's the problem, you go remove the problem. You don't just do a general womb scrub. Now, in those pictures that we see in our slides there's a fibroid in the cavity. You can see our instrument there going straight to the fibroid to cut out the fibroid. And the bigger picture is actually a miscarriage. We put the camera inside the womb. We see exactly where is the miscarriage, where are the products of conception, and then we remove that part only without damaging the womb any further. So DNC is bad for fertility. And after clearing the pathology in the womb, it is recommended that one must instill a gel that will prevent adhesions or scar formation, because any surgery in the uterus can induce scars. Big problem is blocked fallopian tubes. Now, these tubes can be blocked because of previous vaginal infections that are sent into the uterus and then are sent further up into the fallopian tubes and then block the fallopian tubes. Another reason, common reasons for blocked tubes is surgery to the, like ectopic pregnancy, appendix surgery, or any surgery to the pelvis can cause damage to the fallopian tubes. And commonly endometriosis as well can block the fallopian tubes and cause infertility. In fact, that's one of the ways in which endometriosis causes infertility. So once the tubes are damaged, there are 2 management options to go around that. The first is we go operate the patient, or we bypass the tubes and do IVF. Now, there are specific indications as to when should we do surgery and when should we do IVF. Now, tuboplasty or fixing the tubes is ideal in the young patients, in those patients with secondary infertility, in those patients with what we call the good prognosis tubes. In other words, the fallopian tubes are not badly damaged. They are damaged, but they can be fixed. and where there's peritubal adhesions in stage 1 or stage 2 endometriosis. But it is inappropriate to do surgery in somebody who's 40, 45 years old because they require IVF in any case because of their age. It is also inappropriate to do tubal surgery in a patient where the husband's sperm count is subnormal because you have to do IVF in any case. So there's no point in subjecting the patient to surgery and to IVF. And in those badly damaged tubes, the so-called poor prognosis tubes, we recommend that surgery must not be done, rather go straight for IVF. And then in those patients, and this is a common problem, who had previous surgery on their tubes. The tubes were fixed before and it didn't work. There is no place to have a second operation on the fallopian tubes. That doesn't work. It's going to increase the risk of ectopic pregnancies. Ectopic pregnancy is a dangerous condition and a common cause of maternal deaths. So once you had one operation on the tubes, don't do another operation on the tubes. You have to go for IVF. Patients with stage 3 and stage 4 endometriosis, you have to undergo IVF, or you might do surgery to try to fix the tubes, but IVF would be the better option. And then those patients with very thick and dense adhesions, it is better to go straight for IVF than to subject them to surgery. Now the last point would be about the other factor, the peritoneum or the endometriosis, which is very, very common. Now endometriosis causes infertility by a lot of ways. One of the ways is to impair the inner lining of the womb. Endometriosis also impairs the interaction of the sperms and the eggs. And as you can see in those pictures, endometriosis also moves the fallopian tubes away from the ovaries, so we can't pick up the eggs from the ovaries. And in this case, we have to do surgery or we have to do IVF. Please note that with endometriosis, you don't need to do both. You either do surgery or you do IVF. And the reason for that is this. Now, if you look at this graph, the pregnancy rate of IVF in these patients with endometriosis is up to 55–60%. And the pregnancy rate of the same patients with surgery, but good surgery under good hands, is the same. So doing both, you don't up it any further. It will be the same, around 50–60% with surgery or with IVF. So the patients can have any of the two. The older ones, one would recommend IVF probably. The younger ones could have a choice between IVF and surgery. Thank you very much.